I'd like to summarise aspects of our paper which describes patients with faciobrachial dystonic seizures in association with LGI1 antibodies and aims to discuss both the clinical and some of the more scientific pathophysiological aspects of this illness. So in this study we focused on the patients with LGI1 antibodies and we focused on the clinical syndrome of faciobrachial dystonic seizures, which was discovered in the context of the more typical encephalitis, which is now very well known to neurologists. From this study, what we wanted to do was try and pinpoint a number of important clinical questions which remained unanswered. Can we decipher the relative effects of immunotherapies and anti-epileptic drugs? Are the timing of the therapies important? Might change clinical practice if they were. Are patients with seizures but without the cognitive impairment? Remember, they were originally described in the context of an encephalitis, but are those without the cognitive impairment important, common and different? And do we have insights into the pathophysiology from studying these patients' antibodies?
For LGI1, there wasn't very much known biochemically about this protein. There was a hydrophobic region which was suggested to be a putative transmembrane domain, so we tried to express this protein in the HEC cells. It turned out that it wasn't bound on the surface of the cells. It didn't have a transmembrane domain, but it did non-specifically bind to the HEC cells. And when we looked down the microscope, we could see very, very delicate punctae on the surface of all cells on the cover slip. So we modified the test. We took another protein that we have in the lab, Casper2, and we made a construct with the extracellular portion of LGI1 and the transmembrane domain of Casper2 and the cytosolic domain. When we expressed this on the cells, there was a much greater surface expression of LGI1 and therefore increased the signal of the test.
With the LGI1 antibodies being detected, we then found that the patients were often old, they were often in their 60s and 70s. You can see that there are no children. And interestingly, we found no Afro-Caribbean patients in our population, despite them being prevalent in the baseline, certainly United Kingdom and US populations. Secondly, what we did is we divided these patients up with and without cognitive impairment. And here you can see the patients with cognitive impairment had plenty of abnormal tests, although rarely fulfilled the diagnostic criteria of encephalitis. They more had an encephalopathy. However, the patients without cognitive impairment typically had normal investigations, making a clinical diagnosis imperative here.
What was striking in the study was the dramatic effect of immunotherapy compared to the lack of effect of anti-epileptic therapy in cessation of the seizures themselves. For each week that people had delay in treatment with immunotherapy, there was 5% less chance that you'd be able to stop the seizures. Patients with cognitive impairment had higher MRS scores throughout the course of their illness, which would be expected. They unfortunately had reduced independence and worse outcome functionally. Despite treatment at 48 months, they were still worse off than patients without cognitive impairment. Faciobrachial dystonic seizures predate the development of cognitive impairment. In the vast majority of patients, stopping faciobrachial dystonic seizures stopped the development of cognitive impairment.
We developed an internalization assay based on the soluble LGI1 and known binding partner for LGI1, ADAM22, that we expressed in HEC cells. We incubated those complexes together with patient serum to allow for binding of LGI1 specific antibodies. Those cells were then visualized utilizing fluorescently labeled FAP2 antibody to human IgG. When performed on ice, those experiments show membrane binding of LGI1 specific antibodies. After several hours at 37 degrees Celsius, we could observe internalization of the complexes as well as clustering on the surface. Both ADAM22 and LGI1 protein was subsequently detected as a part of those complexes.
To put this model into context now, patients who start with faciobrachial dystonic seizures alone tend to have normal tests, and if they're treated early, they can return to virtually normal. However, if you're treated late, particularly if you've developed cognitive impairment in this time, you rarely return to your baseline level of function, and you often develop a fixed deficit, which can be a combination of complement deposition in the brain and or the modulation of LGI1 and the ADAM22 complex by the patient's antibodies.